Hey, and welcome. I'm Paul Joyner, the senior pastor at Zion. We're glad that you've joined us. We wanted to talk through how some are thinking biblically through COVID, particularly the science and the medical side. So we've got Dr. Thomas Quinn here. Thomas is a graduate of Ole Miss. Don't hold that against him because he then went to Vanderbilt to do his medical school and also a fellowship at the University of California, San Francisco, if I remember right. Thomas is also one of our elders here at Zion and the medical director of the ICU at Murray Regional, so he's in the thick of things. Um, as we get started, I thought we would do this as question and answer time. So I'll just go through some of the questions that some of you submitted. If you're on Facebook, you can submit some questions in the comments section and we'll see if we can get there. We're going to ask the questions that were submitted first. So I wanted to start here, Thomas, or should I call you Dr. Quinn?
Thomas.
I, so much of the way people think through and interpret data seems to be through political lens. So I just thought I'd get this out there. You tend to lean libertarian. So there's that. So if you're wondering where Thomas is coming from politically and how that might influence his reading of the data, hopefully it doesn't influence his reading of the data and the science too much. But if you're wondering, we just thought we'd put that out on the table. Thomas, let me start here. This is something that I think I've heard a lot. Some are saying that this really isn't a pandemic, and so what's the most basic definition of a pandemic?
Well, the World Health Organization says that a pandemic is essentially global spread of a new disease. So this clearly meets the definition of a pandemic.
This question was submitted. I thought it was a good one. To whom does Murray Regional Medical Center look for authoritative information and why? Or maybe who do you look to too?
Sure. Well, first of all, we have an excellent infectious diseases physician, Dr. Deborah Goldsmith, and she heads a team of infection control experts. And for things like infection control, prevention of infection, they look to the CDC mainly, but also the Tennessee Hospital Association and the Tennessee Department of Health are excellent resources that we access, and we try to follow those guidelines. Personally, and I think for most of the medical staff, we read primary source literature, things like the New England Journal, to keep up to date. On this topic, I've been doing a lot of reading, as you can imagine, over the past 6 to 8 months.
For the average person, it seems like one of the things that it's often confusing is where should I get my information? And so for someone like me who has no idea how to read something like the New England Journal of Medicine, where could you go for good information, reliable information?
I think that's one of the hardest things about today. The reason is that we don't have common sources that we all trust anymore. I think you probably should read a variety of news sources. So I like you mentioned, I tend to lean a certain way, but I think we probably should read across the spectrum. Some mainstream sources, some of the sources that are your favorites, so that you can get an accurate picture of what's going on. As far as sort of technical things about COVID, though, the CDC is an excellent site. And again, the Tennessee Department of Health has a very good website that can give you information about COVID.
Another thing that seems to come up a lot is that, for the most part, media outlets only care about the total number of actual COVID cases, without regard to some of the finer grained details, particularly, bringing in whether someone's asymptomatic, mildly symptomatic. Everything gets lumped into hospitalized, death rate. Everything seems to get lumped in. What are your thoughts about that kind of data?
Well, it depends on the question you're asking. So, if I want to know what's going on with somebody asks what's going on with the COVID-19 pandemic, you want to look at all of those data points. So, the total cases and the demographic that is now testing positive, that gives me a picture of what might be coming as far as hospitalizations. If we see that there are a lot of people in the older age group, for instance, testing positive now in our state, well, those are people at risk. So that's helpful as well. But also, if you're wanting to know, well, just how bad is this disease, look at the hospitalization rate and the mortality rate, and that'll tell you a lot about how this compares with other things that we've experienced.
What is the current mortality rate?
The best estimate that I have seen recently is between 0.7% and 1%.
How does that compare to like the flu or other widespread viruses?
Compared to the flu, the general thinking on flu is that the mortality rate for it is about 0.1%. So 7 to 10 times the death rate for influenza.
Let me jump from there, because one of the things that keeps being put out there is we need to get to herd immunity. With those kind of numbers, what does that look like? Is that a good immediate target? Should we just let this thing run so we can get to herd immunity?
That's a good question, and I've had people ask that question a lot, and people are advocating that. Thinking about herd immunity, basically, herd immunity means enough people in the population have had the disease that it doesn't transmit readily in the community. So we won't experience epidemics, small epidemics of it. The best estimates I've seen for herd immunity, in other words, the percent of our population that's going to need to have this before we achieve herd immunity, is I've seen as low as in the 40s and as high as in the 80s. So if you think about, let's put that in the middle. So 60% of the population of the United States needs to have had this to achieve herd immunity. That is well over 100 million cases, and well over 150 million cases, right? Because there are about 330 million people in the United States. If you then think about the current best estimate for mortality, in that context, you're looking at between 1 and 2 million deaths, and probably 4 to 5 times that number of hospitalizations. That is not something that we should try to achieve, or that we should think about lightly. And certainly we can't try to get there quickly. That would overwhelm the healthcare system.
Are we far enough into it that the death rate is pretty stable right now? Early on we just weren't sure, but now going since March, is that kind of stabilized?
I think the number, if you just look at the raw numbers, so number of known cases versus the number of deaths, that number has continued to go down. And we would expect that, right? Because we're testing more and more people, so we're catching more and more cases that are mild. That is what we would expect. These estimates of mortality, the more accurate estimates of mortality, are a little bit more sophisticated statistics than just looking at the raw numbers.
And that statistical model is based on enough data right now that we get a good sense that that's a good mortality rate, good sense of what the mortality rate is. We've seen enough worldwide.
I think so. You know, again, I've said this before. I'm going to hold that with humility, because everything is changing. I mean, and that's the very nature of what's going on. It's new, and we don't know much. But I will say that I saw estimates of mortality of between zero point 0.4 and 1.4% a few months ago. And in fact, this newer estimate is sort of within those bounds. So I think it's probably it's reasonable.
We You had brought this up earlier. Um, we're testing more, so we're seeing more cases, and that's sort of the argument goes. Of course, we're seeing more cases, we're doing more testing. Is there, besides cumulative case count, are there other metrics that we can look at to see how active the virus is in our community?
Yeah. So just looking behind raw case numbers, and you're right, the more testing you do, the more positives you're going to have. And that is helpful from an epidemiologic standpoint. But if you look at the percent of positive tests, so the percent of tests that you do that are positive, when that's going up, then that's an indication that this thing is actually spreading, that the epidemic is worsening. That was actually shooting up pretty quickly through June and July in Tennessee. I think that at least the last thing I saw, and I think this may have been more nationwide, I think that's starting to maybe level off some, and that would be good news.
I looked at those numbers today. In Tennessee, it's 8.8%. In Alabama, it's 20. In Mississippi, it's 25. Are those? I mean, what do I do with those numbers?
Yeah, so there are two possibilities. Tennessee has been actually, even though testing is limited and it's been frustrating, Tennessee actually ramped up their testing quite a bit faster than some of the surrounding states, and did a pretty good job, I would say. Some of these other states, they may be having more trouble ramping up their testing. So that may be influencing those numbers more. I think the other thing you need to look at is the number of hospitalizations. So if that's going up, then things are intensifying. And then, of course, sadly, death rate, we can watch that too.
Since you mentioned hospitalizations, what kind of things are you seeing? I mean, you're literally on the front lines in the ICU. What kind of things are you seeing that's alarming you?
Well, what I've seen, the most alarming thing is, and of course, what I do is I take care of the really sick people. The most alarming thing that I've seen is that once people get sick enough with this disease to require life support, to require a ventilator, the death rate is it's terrible. And so and it's extremely frustrating, and for the whole staff in the intensive care unit, it's a bit demoralizing. And we have actually, one of the other sources that we go to for information is talking with our colleagues around the country, and they're all experiencing this. This disease is, when it gets bad, it gets really bad. And it can be a very helpless feeling for people trying to take care of these people. So that's the most alarming thing. Early to mid-July, we had a surge here, a small one, thankfully, nothing overwhelming like we've seen in other parts of the country. But we were up to about 30 patients at Murray Regional, and we had, at one time, in our 26-bed ICU, we had 14 COVID patients. And that may not sound too bad, but you have to remember, we have to take care of everybody else that's sick too. So, other kinds of pneumonia, stroke, heart attack. And patients with COVID, they are not in and out of the ICU. They stay there a long time. So we have been really squeezed with place to put people.
So one of the things that has been said very early on was we can't overwhelm the system.
Yes.
And that's not just beds and ventilators.
Yes.
It's the people who are actually caring for
Yes.
the patients as well, because they got to care for other people too.
Yes.
We don't want to burn you out.
So there are a couple of things that concern me and that concern the rest of the administration at the hospital and in hospitals around the country. And you mentioned burnout. These patients with COVID, are very labor intensive to take care of. And a lot of that has to do with the isolation procedures. And they're also, like I said, they're very sick. So, sort of constantly in and out of the room in the intensive care unit. But the other problem is staff getting sick because there is a transmission rate to the healthcare workers. And of course, at a time when we need staff the most, we have people out sick.
Some have said that I've had this conversation with a number of people that the numbers are inflated because hospitals are being paid more if a patient is diagnosed with COVID. You're smiling. Have you seen that from inside?
That's one of my favorites. So, there's a word for that. If the accusation is that people are falsifying medical records, the word for that is fraud, and that is audited. Those things are monitored by the federal government, and nobody wants to see the IRS, the general public. Well, I can tell you, nobody wants to see the Center for Medicaid and Medicare Services in their hospital either. I can tell you that is not going on.
You're on the front lines. If they make it to your floor, that's bad news. Have you been pressured in any way, or even suggested that you put some COVID down as a cause of death or a diagnosis?
Absolutely not.
The hospital's not.
No.
You're not being paid to say that.
I am not being paid to say that.
So that I thought this would be good. We talked through a lot of the hospital medical stuff, so I thought I'd throw you a softball here and transition to the easy topic of masks, because nobody seems to have opinions on this.
Yeah.
So I thought we'd just wade into the shallow water of masks. So let me start here, because one of the things that I've heard and has been voiced to me is, aren't we just operating out of fear? And I think it's a valid question. Isaiah 43:1 commands us to fear not, because the Lord is with us. He's redeemed us. And so, sort of the thinking goes that we shouldn't, as God's people, as His redeemed people, be operating out of fear. Is a move towards mask wearing or shutting down or taking other precautions fear-based?
So short answer, no. We are commanded to do not fear, but we, if you read Proverbs, there's this whole thing about prudence, and Proverbs 22:3, I wrote this down. The prudent sees danger and hides himself, but the simple go on and suffer for it. So we are navigating this, right? We do not want to live out of fear. The Lord Jesus will not let a hair fall from our head without His knowledge of it. So yes, we shouldn't live out of fear, but we need to live with prudence. Would you say that a soldier who goes into battle with body armor on is being cowardly or living out of fear? Well, of course not. We wear protective equipment at work, and it is the wise and prudent thing to do. look at the Westminster Confession, or actually the larger Catechism on the Sixth Commandment, and it not only instructs you to value the life of others, but it also actually instructs you to value your own life as well. We should not throw ourselves away easily. We don't belong to ourselves. We belong to Jesus. So I think we need to take prudent precautions. The other thing about masks, since we're on the topic, is there are really two reasons to wear a mask during this pandemic. The first, and the one for which there's probably the most evidence, is to keep you, if you have it, and by the way, I think the evidence suggests that you can pass this on to somebody else even if you don't have symptoms or before you have symptoms. So the evidence suggests that wearing a mask will reduce the chance that you're going to pass this on to somebody else. And that's why they're recommended. So to not be a part of the problem in general, but also, you don't want to give this to someone who's vulnerable. I mean, the consequences can be catastrophic. The second reason to wear a mask, though, is, and there is accruing evidence on this front, that wearing a mask may reduce your chances of getting it if you're exposed. In fact, there is also some accruing evidence that if you get it in that situation, that you may get a lesser disease because there does seem to be a dose response when you are exposed to this virus.
Meaning, the less of exposure to the virus, there's a chance you'll have a milder response.
Yes, and that is very preliminary data coming actually from San Francisco. And again, I think we need to hold these. I think the frustrating thing about this is, again, things are changing all the time. And even at work, the recommendations coming from the CDC are changing rapidly. So we did one thing last week, we're doing a different thing this week. But we're learning more and more as we get more data, more information about this, we change our practice. In 2 months, might the CDC come out and say, well, it looks like maybe that doesn't help. Yeah, they might do that. So I think we need to hold this with humility. But I think it's reasonable to think that we can prevent harming somebody else by doing this. And if we love our brother and sister and we love our neighbor, I think it's a pretty small ask.
Yeah, I think, we've talked about this, that, Deuteronomy 22 commands that when you build a house that you put a parapet, a fence around your roof. And if you don't do that and someone falls off your roof, even if they're being careless, then you are guilty of their blood.
Yes.
And I've said, I think, to me, that's a straight line application. Put a mask on, just even if there's a slight chance that will protect someone else. Someone asked this question: what good does it do for someone to wear a mask when other people around them aren't wearing masks?
Well, I think we just addressed that a little bit. Number one, you may, if you have it, the mask may keep you from passing it to those people. And then if one of them has it, it may keep you from getting it.
Yeah, I remember, I've shared this with you, but I was talking to a buddy who had at least 2 instances of comorbidity. He was extremely overweight and had he was actually overweight because of a heart problem. And he asked me why I was wearing a mask, and I said, so I don't kill you. In case I have it and don't know it, you're probably not going to survive if something passes from me to you. And that, I think, surprised him. He'd not really thought about it that way. I think he thought the mask was to protect him from me, but not protect me from him.
Can I add one other thing? I don't think the mask shouldn't give us a false sense of security. If you challenge that, you sort of challenge that system enough, sure, you can overwhelm the mask. So the other things we need to be doing is we need to be doing social distancing, and washing our hands, taking more care than we usually do.
It's a good, the analogy of the seatbelt's been used with the mask, but I think you can carry that analogy into this. Like, a seatbelt's not going to prevent car wrecks or deaths, fatalities, but there's a good chance, and it has proven to be the case, that it's reduced both. It's reduced fatalities. It hasn't eliminated fatalities, but it sure has reduced it.
If you drive fast enough, the seatbelt, you can overwhelm that.
Or crazy enough. Or another circumstance. There's too many variables to prevent something, but to reduce the probability of is a good thing. If you value human life because it's created in the image of God, to reduce the probability even slightly is a good thing, a valuable thing. And someone had said recently to me, if Jesus calls us to take up our cross and follow him for the sake of others, if that's the second great commandment, and all I have to do today is put on a piece of cloth to take up my cross, then I've made it's a win today.
That's right. It doesn't get any easier.
No, it doesn't get any easier than that. Someone had, this was a question, it's a little bit longer, so there's, I was wondering, since we've been told from the beginning that the COVID virus particle is too small to be trapped by a mask other than N95. So the analogy that's often been used is you can't stop a mosquito with a fence. How effective are the masks, and do they give us a false sense of security?
Well, I think, again, I would warn against a false sense of security. We do need to be doing the other things that I mentioned. And that's it's a good point, and it's a good question. The masks that we're wearing are not, they're not going to stop a single viral particle. But what they can stop are these droplets, which are quite a bit bigger. So they can keep you from sending them all over. And they can also, if someone coughs or sneezes, keep, those larger particles from, getting, in your nose or your mouth. They won't stop your eyes, by the way. Those are still unprotected.
So, again, seatbelt analogy, there's no fail-safe.
That's right.
Unless you put yourself in a bubble and...
That's right. Which I'm not advocating. Yes.
But if the cumulative effect of these steps has the potential to reduce transmission, then we're slowing it down. And if we're slowing it down, then we don't have to go back to shutting down the economy. All of these things are minor things that have the potential to accumulate. In our family, we talk a lot about what I call stacking. There's no silver bullet, but if you stack enough things up, maybe you'll make some progress in life. Don't look for the big win. Just look for a bunch of little wins stacked up, or you don't get in a hole by falling into it. You dug yourself into it slowly. So these things like masks and social distancing and hand washing and limiting exposure has the potential not to be the cure-all, but to slow things down.
That's right.
And protect our neighbor.
That's right.
To love God by loving neighbor.
Yeah.
So that's a setup to why are we wearing masks in worship?
Yeah. So good question. I think we've just talked a lot about the evidence behind masks and slowing transmission. It seems like that worship in the right situation is particularly risky for transmission of COVID. So without social distancing and without wearing masks, and particularly with singing, there seems to be a particular problem with that. There have been reported outbreaks within the church setting. One of the most notorious of those outbreaks actually is within our own state, Cleveland, Tennessee. There is a church there that held, I think it was a pretty long worship service, like 2 or 3 hours. I don't think they were particularly aggressive about social distancing, and they clearly were not wearing masks. The pastor said that. And there is an account from or an interview of that pastor in the Chattanooga Times, and that pastor said that he has lost count of the number of members of his church and those that attended this service who contracted the virus. So it has the potential to be a bad scene. That I also personally have taken care of a couple of patients who contracted this virus at worship. And again, they were not taking the same precautions that we're taking. And one of those unfortunately died. And one, had probably a life-altering illness.
There's been some, and I think before I transition to the next question, I think one of the reasons that we're doing it in the gym is because air volume seems to be a buffer that helps with transmission rates, and that's a big space with a lot of air being turned over, so that makes it safer. We can social distance a lot easier there, but again, stacking, social distancing, air volume, masks are an important piece of that. I was having a conversation with one of our older saints who was very thankful for the steps that we had taken with mask wearing and social distancing, who had been able to come back. And it is a particularly difficult time in his life and really needed to be there. And because of the mask wearing, felt comfortable being there, needed to be with God's people, needed to be with God, his Redeemer, and felt comfortable being there, even though he was higher risk than me. Stacking. The more we can do to protect our neighbor, the better off our neighbor is. There's a lot of talk about masks being dangerous for our health. So one of the things that I've read is if you've got the virus and you're breathing it into your mask, doesn't that just mean that it's all collecting right there and it's dangerous?
That honestly doesn't make a whole lot of sense, but no. I mean, the answer is no. That's not the way. That's not the way you get rid of the virus. Your immune system gets rid of the virus. You don't get rid of it by breathing it out, and there's no evidence that accumulating the virus in some way like that is going to cause you to get sicker. We, as far as experience with that, we wear masks, especially now, all day at work. Surgeons have worn masks all day at work for generations now, and it is a very safe practice. I don't know of anyone who's had, short of people who are claustrophobic. There are some people who have real issues with that, but I don't know of anyone who's had a real problem with wearing a mask.
Are there certain masks that are better than others?
Well, probably the surgical masks are better, but they are not. They're not plentiful, and I think that the cloth masks are considered adequate to reduce the production of droplets. So I don't know what the percentages there are, but we are now mandated to wear surgical masks at work.
The K95s?
No, the regular surgical masks. Okay. N95 is the special mask that we have to have on when we go in a COVID room.
So N95, surgical masks.
Cloth masks.
Cloth masks.
Yes.
And should we be throwing those out? Should we be washing them? If
Which
so,
ones?
how often?
Which ones?
The cloth masks.
The cloth masks need to be washed.
How often?
I don't know the answer to that question. when it smells bad.
But
Often you wash your clothes.
well, the one question I thought that I had about masks, because I am pro mask, and you can't tell if you didn't know. The one question I did have about masks is, I think the pandemic has revealed a lot about all of us. We're finding things about us that we don't like, and so the mask thing has made me wonder: does my breath always smell this bad?
I said the very same thing. Lots of people at work are chewing gum now.
So I'm going to take that as a sidestep from my question. Man, if it's not been bothering you, my breath, it has been bothering me recently.
I haven't noticed.
That's because we're social distancing. So let's transition, and if you've got questions, feel free to post them on Facebook. When we get done, we'll, with the questions that were submitted earlier, we'll try to hit some of those. So transition now to the school question. The CDC published on Friday that suggested that kids go back to school. That was their direction, that kids go back to school. Most of the school systems in Middle Tennessee had already decided to do that with different approaches to reopening. And you can defer this question if you want. What are your thoughts on the reopening of schools?
Yeah, so I don't know any parent who doesn't homeschool that doesn't want their kids to go back to school. I think it is, it's good for the kids to be around their friends. They need to learn. We need to educate our kids. I want our kids to go back to school. I am concerned that we don't have this sort of tamped down enough before we have sort of thrown gasoline on the fire. And I don't know that I have a real good rational explanation for why I think it would be a good idea, but I think it would have been a good idea to wait until after Labor Day, and let's work on this pretty hard as a community, and then start school. But I don't think people need to be overly concerned, about their kids if they get this, because it seems that severe disease in children is quite rare. But you have to think about the teachers, and you have to think about who our kids live with, and are they at risk. And I'm very concerned that 4 to 6 weeks down the line, we're going to start seeing the consequences of going back to school.
Any precautions that you for kids who are starting back to school? And are your kids starting back to school?
They are back to school.
That's what I thought. Today
Yes.
started back, right?
Yesterday. Yes.
So you have concerns, but you are sending your kids to school.
Yes.
Um,
I've instructed my older two that they should mask all day.
all day.
Yes.
That was my next question.
Yeah.
Because Murray County has said they're not mandating masks, Murray County schools, Zion is not mandating masks, Agathos is not mandating masks, but your advice would be all day.
I think that they should have. They're leaving it up to the kids. Well, I wanted to ask, well, have you met any kids? I mean, because I think the fact is, I don't know for sure, but given the nature of kids, particularly adolescents, it's hard to imagine that there's going to be much masking going on, or social distancing for that matter. I think it has the potential to be a big problem.
Yeah, social distancing with little kids lasts about 1 minute.
Right.
Yeah. They also tend to be tactile, and it's one of the sweetest things about. I think it's for my family. It's been one of the hardest things, is is watching our youngest not being able to. She's a very social child, and I've learned that we cannot meet all of her social needs, and yet you can see her suffering and having a difficult time because she misses people. Yeah. And so those children getting back to school, and now, you can't police kids all the time.
Right.
And so it's going to be difficult.
It is.
So we've talked about, we've heard a lot about second wave coming this fall. Now that we're starting back to school, kids are going back to college, but there's the potential for a second wave. What does that mean? What does second wave mean, and when would we expect it?
Well, a second wave would mean a second spike in the prevalence of this disease. For us in the hospital setting, it means another wave of people coming into the hospital, sort of flooding the hospital, very sick. We know that for the foreseeable future, Lord willing, we'll have a vaccine, in the next maybe 6 to 12 months. But for the time being, COVID-19 is part of life. What we don't want to see is a situation like New York. And I think there are multiple reasons why I don't think that would happen here. Right now, I have a good friend and colleague in Baton Rouge, and they are experiencing their second wave. And the numbers of patients that they're seeing in their hospital system are they're kind of staggering.
So in Baton Rouge, is that a second wave or a spike, a resurgence in the first wave?
Well,
or is it hard to tell?
I guess I would not distinguish between those two. It is a second spike. No, I don't think it ever went away down there, but it's it got better through June for them apparently, and then but through July. My colleague down there says that they admitted or were admitting 20 COVID patients a day to their hospital system. And as of a few nights ago, they had something like 140 patients in their intensive care unit and had literally overwhelmed the oxygen capacity, the oxygen system of their 800-bed hospital.
They had 140 patients in the ICU.
That's correct. No, that's two sizable hospitals. But yes, and at one point in the spring, they had filled 13 hospital units with nothing but COVID patients. The concern here is there's not really anything. Of course, Baton Rouge is a larger city. It is more urban. But could we see that here? I don't see a good reason why we wouldn't if we sort of cast off all precaution and just let this thing go.
So let's talk about testing. Someone had asked that she'd seen some hints about blood type affecting severity of symptoms. Is there any truth to that?
Yeah, that's a good question, and kind of fascinating. But the answer to that question is yes. There does seem to be a higher prevalence of severe disease or incidence of severe disease in people with type A blood. And I don't think anybody knows the answer to why. And that actually, there was a recent genetic study published in the New England Journal that confirmed that.
Does everyone with COVID lose their smell and taste?
No. I actually, you kind of you tipped me off to this question, so I looked it up last night, and the CDC says that 22%. At least their database said 22%. I think that's low though. In talking with people who have not, aren't sick enough to come see me, but have had it, I think it's quite a bit higher than that. But I don't think it's everybody.
That seems to be it. The people I've talked to is either the fever or the loss of taste and smell that they're like, oh, I might need to go get tested. Yes. Since we're on the fever, what's the fever indicator? Like if your fever or your child's fever is over what, you should go get tested?
Well, everybody, that's kind of all over the map. So, so there are differing opinions on that. I would say over like 100.1, but I would talk to your pediatrician. Before you go in and get tested, talk to the pediatrician, because they may steer you otherwise. And I will say this: I'm not, I don't treat kids anymore medically. So I'm not quite as up on pediatric literature.
Why can't we get test results in a short period of time?
Well, basically short answer is that we have overwhelmed the testing system. In other words, so many people needing or desiring tests that the large reference labs and the local labs, they can't keep up. They can't process the specimens fast enough. I will say that there is a project going on within the federal government that the National Institutes of Health is spearheading, where they are trying to rapidly develop new technologies for testing, new platforms for testing, and the goal is to have that some of these things up and running by fall. And their stated goal is to be able to test 2% of the U.S. population a day. That's 6 million tests a day. Wow. So hopefully they'll meet that goal. It may be a little bit later, but they are working very hard on getting in front of the pandemic with testing.
And so currently, I think the number that I'm hearing is 2 to 7 days. Is that accurate?
It does fluctuate depending on sort of demand that day. I will say the last thing I saw with our outpatient reference lab was faster, quite a bit faster than 7 days, something like 2 to 4 days.
And if someone gets tested, do they need to quarantine at home until they get results?
Yes. You'd hate to find out that, yes, in fact, you were positive and you've been all over town spreading this.
Apart from temperature or loss of taste and smell, what are some other indicators that you should get tested?
So you mentioned, so fever, aches, basically flu-like symptoms. I will say a fair number of people have, GI type symptoms, nausea, vomiting, diarrhea. Some people have only those things. We've caught some cases with just that. But malaise, that's just sort of general feeling bad. The feeling. You've had viral upper respiratory infections all your life. And I'll say that's one of the hard things about this too, because we're told don't go anywhere if you're sick. Don't do whatever if you're sick. And if you're like me, you sneeze some in the spring and fall, and I've got a little scratchy throat. Am I getting sick? Am I not getting sick? That's why this is so difficult to control. Is that you can, if you're developing the disease, at that point you can spread it.
Well, and I think that's been I've experienced this summer has been a difficult allergy season for me. I've had that discussion with a number of people, which is then often triggered a conversation. Is this just allergies, or do I need to get tested?
Yes.
Better off getting tested?
Probably better off getting tested, or at least calling into your physician, and they may ask you a series of questions before deciding to bring you in to test you. But it highlights the reason why we need to do the basic things that we've talked about. Wearing a mask, because let's say you are incubating this. Maybe that couple of sneezes was the first sign that you've got this, and so I certainly don't want that to give you a false sense of security, but maybe it will reduce the chance that you spread it. Same thing with the social distancing.
Someone had asked, how concerned should I be about visiting my grandchildren?
Yeah, that's a hard question because I know, children, they need to see their grandparents, and they need to have a relationship with their grandparents, and grandparents, desperately desire to have a relationship with their grandkids. And I think that this is a personal weighing it out decision. I don't have a good answer to that. I think if you are at particular risk, so things beyond age, more than age, then are there things you could do to see your grandkids and maybe minimize your risk? Like you wear a mask, maybe they wear a mask, but of course, if the kids are sick, they do not need to be around their grandparents. But that is a very hard question.
Treatment. What about hydroxychloroquine?
There were early indications that it might help. And that was based on some what are called observational studies. And the problem with observational studies is that they are rife with bias, confounders. The fact is, if I see 25 people with COVID and I give them all these treatments that I'm giving them, I have no idea what's really working. Or even if I give them one treatment, I don't really know if that treatment is working, right? Because they might have gotten better anyway. Or if they die, they might have died anyway. The way that we determine if a drug or an intervention is working is that we conduct clinical trials where 1,000 people or more or less, depending on what it is, 1,000 people get the drug and 1,000 people get placebo. And the best ones, the physician doesn't know what they're getting, whether placebo or the drug, and the patient doesn't know what they're getting. It's concealed from them so that my bias doesn't enter into that. There have now been several of those studies done with hydroxychloroquine, and it has not been shown to be of any benefit. And that's, unfortunately, this issue's become politicized. Look, we would all be jumping for joy if we had a drug that we could give people and know that this is working and going to prevent severe disease or save somebody's life. We would be readily giving it. But now I think the studies for this drug, the studies show that it's of no benefit. So we have abandoned hydroxychloroquine as a treatment in our facility, and other large centers. I think most large centers have abandoned the use of hydroxychloroquine.
Are there what effective treatments are you guys using now?
So there is one well-done study that shows that a particular steroid helped improve mortality in sick people, so hospitalized, needing oxygen people. and that's Decadron, and you may have read that in the press. So we're using that. And I will say, I think that study needs to be repeated. The best evidence can be reproduced. But we are using that, and there's a drug called remdesivir, which actually inhibits the replication of the virus, the reproduction of the virus, and we are using that as well. I will say it's hard to come by that drug. There's a shortage, as you can imagine why, but we have been able to obtain it for our sick patients at Murray Regional.
You had said earlier that our vaccine was 6 to 12 months away. That's a long time.
Yeah.
Is that a conservative estimate, or is that just an estimate?
Yeah. Let me add to the treatment, because it sort of relates. The thing about vaccines is it produces immunity, which is the problem with this disease, is that we don't have any immunity. And so on the treatment side, another thing we are doing is giving what's called convalescent plasma, which has the antibodies to COVID. So it's basically someone who's had this disease, they donate their plasma, and we give it to the patient. There is not great evidence that works, but there is some observational evidence that it works, and it has plausibility. Go ahead.
Is that a long-term solution? I mean, is that like they are then immune for the rest of their life?
No.
Is that a short-term?
It is actually treatment for people who are very sick with the disease.
To help fight.
Correct.
Immunity.
Yes. To reduce the viral replication within their body. On the vaccine front, the 6 to 12 months, I see a lot of optimism out there that we would have a vaccine early next year. People like Dr. Fauci and other vaccine experts around the country have said that we might have a vaccine around the year, around the turn of the year. If we were to get a vaccine that fast, within a year of actually seeing our first cases of this, that would be an amazing scientific feat. Generally, it takes 10 times or more longer to develop a vaccine to a new disease. But I think there is good reason to be hopeful that we'll have one. The United States federal government and other governments around the world are conducting the tests of these vaccines sort of in an unprecedented fashion with unprecedented speed. They are literally going from one stage of development to the next, within days to weeks. So I think there's reason to be hopeful.
Is there evidence out there establishing that once you have immunity, you are now immune for the rest of your life, or is that immunity short term, and can you get it again?
Yeah, we don't know. There have been people. There are case reports of people getting it again, but this is hopeful. And I think there's again reason to hope that even if your immunity wanes, you at least have some immunity. So able to knock this down to something like the flu. You can get the flu every year because the flu changes a little bit. Your immunity wanes. Most people don't get it every year, thankfully, but you do have to get a flu vaccine every year, and it may be like that. I've seen probably at least 2 doses of the vaccine for it to be effective, if you've had this before or if you have received the vaccine, your immune system at least has some memory of the disease and at least has some head start. Right now it's got really minimal. it's new, and that's why it's so virulent.
Um, let me circle back to the masks. Some of the masks have a valve in them. Are those effective? Good? Should we prefer those, or as to other kind of masks, or?
Yeah, the masks with a valve, I would not prefer. I mean, in fact, I would recommend against those. And again, if you think about the primary reason for wearing masks, sort of the best evidence behind wearing masks is to keep you from spreading it to somebody else. Well, those masks that have an exhalation valve, you're still putting stuff out through the exhalation valve. I guess if there were a filter, but I don't think most of them do. So, for instance, at work, they will not let us wear those.
I was just thinking that I was thinking about what masks are better than others to prevent something from going on the offensive. So they act defensively, and so you need an effective defense. Because I've been thinking about getting a University of Tennessee mask, which has no effective defense or offense. So there's a good chance that just will do nothing.
Yes,
that's good. And that's all the questions I had.
If there's any mask that could infect itself, it would be that
one. That's all the questions I had. Is there anything that you wanted to follow up with that we didn't hit?
No, I think one thing I do want to follow up with on the herd immunity front is, really we will probably in all likelihood achieve herd immunity. It's whether or not we get there slowly, and we can sort of sustain it, or do we get a vaccine? That's also herd immunity. So that's how polio disappeared, and that's how other childhood diseases have largely disappeared from the scene, is through herd immunity. So if we can get a vaccine, then we don't have to have the painful way of getting herd immunity, which is most people getting it.
And most people getting it catastrophic for the system and for life.
Correct.
Yeah. Well, thanks for joining us. I hope we answered at least some of your questions. Feel free to reach out to us if you have more or things that we didn't cover or thoughts.